Thanks, Peter. Look, I hope this morning I'll tell you a little bit of a story about what Canterbury District Health Board, and more so the Canterbury health system, has done to cope with complexity, because it really is a story about thinking about a system in a different way, where we stopped doing what we were doing, reconceptualised and took over. But what you can see in front of you, the whakatoki, he aha te mea nui o te ao, is really important, because it is a guiding principle for the whole system. And in this morning's first talk, I was talking about what's the high level strategy. Here for us, simply identifying that the people, not that one.
No, sorry, I didn't tell you that.
That's all right. Simply identifying that it's people is absolutely key to what we're doing. And so it gives us a focus that 18,500 people that work in health in Canterbury have all got in common. And if you think about health systems, they have come a long way from the Nightingale type ward a long time ago. But it's that engagement in complex adaptive system, and we did try to oversimplify it. And instead of thinking about it in a more complex way, where people are experiencing healthcare over time, where harms occur to individuals, and harms aren't always the result of errors. And so part of the history of Canterbury was we harmed an awful lot of people. Back in 2007, there were 5,500 people waiting on a waiting list for a specialist assessment, and who were hoping, a lot of them, to get surgery. And we said, no, we're going to kick you all off because we haven't got the capacity to deal with that. And so 5,500 people whose GPs had said, we don't know what to do with you, we want to give you to a specialist, all got sent back to that same GP. And it was a point in time where people in the health system said, oh, never again, how could we have done that? And it was a reset. And so this is very much a story from about 2008. At the same time, we also were under-delivering our elective surgery services by 30% on the national target. So our population was missing out. We also had a thing in winter, and the main reason they missed out was we got into winter, and usually about June, and we'd go into a thing called gridlock. And gridlock meant that there simply weren't beds available. And so you couldn't get pushed through the system to get the care you needed. And so there was people waiting in ED for hours and hours, trying to get into a hospital bed where they could get some treatment, and then people waiting there because they couldn't get to the next stage of rehabilitation. And so we'd gummed it all up, and your solution to that is to say, oh, actually, no surgery today, we're just going to give it to all the people who are acutely unwell. And so it's a pretty bad place to start from, but what we did was had to conceptualise that complexity around a person. And you can see here in terms of guiding principles, this is Agnes. And everyone in Canterbury health system knows about Agnes, and it's a motivator. She's part of the reason that we all do our different jobs to make sure Agnes gets the care and that journey that she needs. And so we've got a growing and ageing population, health systems around the world all struggling to do this. What we had to think about was, how do you get the right care to the right person at the right time? And to do that, our approach was, you need to be much more responsive in primary care, and for the vast majority of people that's general practice. We need to increase, instead of cutting off that acute assessment and surgery, we need to focus more on rehab, so to get people well again and healthy. And part of how we do that is stop people going into age residential care. Canterbury had one of the highest rates of people in age residential care, and we put them in too early, and we left them there a long time in an institution to finish their lives. We had to look at waiting times and also think about patient harm. So if we could do all that, we could make the system sustainable. And so in terms of complexity, we had to think about quality, and Deming's work around variation was really important here. We had to reconceptualise. We were part of a system. Not a whole lot of separate systems, not a DHB that 9,500 people work for, and then a whole series of NGOs and providers outside of that. We were part of one system. We had to understand what the variation was and what was causing it. So Mai's piece about the data is absolutely central. It's the data that drives what the system can achieve. And we had to recreate trust, because you can imagine with 5,500 people coming back to general practice what trust they had in their specialist colleagues. And also that shared purpose. And so trust was really important. The idea of the shared purpose was really about that high-level purpose. And so I spoke before about Agnes. That was really it. Rather than having a really defined mission and vision statement, it's about how do we keep people well and healthy in their own homes. And there's a lot of ways you can interpret that, but if we can have everybody with that same vision and the same reason for doing the work you're doing, we can move on. So there you can see one of the things that we did was reconceptualise, and this model's really important. Up in that top left-hand corner is our hospital. Almost all the health systems in the world have conceptualised a hospital as being in the middle of the health system and everything flows to it. So we turned it inside out and we said, Agnes needs to be in her home in the centre of our health system. And so we've got it around keeping people well and healthy in their own homes and providing services as close to that person as possible. And so what we did with this was try and conceptualise our system, and we haven't had too many arguments. It took a wee while to build this up from somebody else's. We flogged it to start off with and rebuilt it. And not too many people moan that they can't see themselves in there. And so you can see that in the centre, but we did have an event, and I'll run you quickly through that. It's when a complex system turned into a chaotic system, and when that chaotic system was, we simply had to react and do the best we could. So just to run you quickly through that, I think everybody here knows most of the history. It's 5 years ago, not a large quake in terms of Richter scale, but the highest ground acceleration that's been measured in any quake, which is why there was so much damage. And so epicentre was close. We obviously lost buildings. We had a lot of people die, including one reasonable sized general practice that everyone was in there was in the CTV building, and so we lost patients, staff, and obviously that whole practice. So very sobering for the health system. There was you can see there are about 6,000 people injured. So that's about 7% of our annual ED number of people that turn up at ED. So we had to cope in totally different ways, and this is where the chaotic part set up. Instead of trying to use our normal systems, people said, why don't we set up triage in the park? And so that was go and do it. And so a number of ways to get around that over time. And obviously landscape changed, and it's for those that go to Christchurch regularly, it's still pretty slow going. With those volumes, our health system should have imploded, but it didn't. And this is where we were incredibly lucky that, if you can call it that, from 2007, from 2008 we started to build the system. And because we'd built some of the bones of a more complex adaptive system, the health system knew what it was doing. We had a plan for 2020. That was our vision. And that got moved forward to 2011. And so people were familiar, they had some of the base, and we could move on. And so what were some of those bases that were in place? The idea of one health system and one budget was absolutely key. And it's not actually true. We have multiple systems, multiple funders and multiple budgets that we could argue about. But we as a system decided to reconceptualise that we would be one system working together using the different funding streams. And so what it did was take away the barriers for why I should do the right thing if we were all helping. What it's also done is and my role as a funder, when we say we're going to do this, people question us as well, and they say, oh, okay, it's one system, one budget. If you're going to spend the money there, where are we not going to spend it? And so the whole concept of saying we're all in this together. I talked about it was about the people. The focus was on the leadership, and DHBs legislatively are a funny beast. Our purpose is to look after our population and provide the services they need. By accident, we also have large hospitals. And so we need to balance the whole of the system and focus on what the population needs, not what our hospitals need. And so taking a whole of system approach, the one at the bottom is really important. We started talking about what's best for the patient and what's best for the system. And so balancing off those two things. And in a room, when you have specialists and general practitioners and community nurses all talking about what's best, they all have different ideas and they regulate each other. And so the complexity of the system we've dealt with by putting people in the same room, making sure we've got the right people in the room and having the conversation. And so they regulate each other. So when a specialist says, oh, I think everybody should come to me for an operation, you've got general practice or community nursing saying, oh, okay, so how's that best for the patient? And so we each question each other to try and get the best solution. And so what you have is health professionals from across the system working together. And instead of chasing what they might see as their personal goals, we're actually chasing goals for the people of Canterbury from right across that system. And so deliberately, phrases such as make it better were brought in. It was recognising we'll never get it perfect, but it can always be better than what we're doing now. We can always make small steps around improving it. And so it was enabling. And so instead of having a few people deciding how we're going to make it better, the responsibility for making it better now sits with the 19,000 people in the system. One of the things that we had to do was move towards clinicians being trusted. And this is analogous to frontline staff. And in terms of making decisions, clinicians are the people who are frontline. They have the patient in front of them. They have the largest knowledge base. So we need to trust them to make the right decision. So the people who are at the coalface, we have to find a way of transferring ownership and decision-making to those people who are right on the front line. We redesigned our care pathways. And so the idea of redesigning that was, once again, getting in a room, deciding what was best for the patient, and to stop the patient from bouncing around to different places trying to get an answer. We had to rearrange the funding to make sure it was supporting and that it wasn't getting in the road. And we've learnt some really valuable lessons on that. I might come back to that one. And we put the patient in the middle. We also, by doing this, we know that the system can respond to a shock, but it is adaptive in the way that it's working. And so the leadership comes from people right across the system, not just from an executive or corporate type approach. And so those adaptive systems, we looked and said, we need a system that's connected. Instead of having a whole lot of bits and pieces, we all need to know what's happening in terms of the patient. So it needs to be connected and it needs to be centred around the people, and with Agnes as our key person. And the third one was we needed to stop wasting their time. And that was a very important unifying metric. If we keep on using patients' time as a key metric, everyone's working to how do we stop to waste the patient's time. We also know that financially we'll be more sustainable. We don't have people getting sicker while they're waiting. If we can get the services to them to get them rehabbed and better, it's actually cheaper for our system. One of the other things that we did a lot of was assessment. And we waited, and we put somebody on a waiting list when they were unwell, and then we assessed them there, and then by the time it was their turn to get seen, they needed assessed again, and then we'd say, oh, well, you're going to need this, and the next person would assess them. We needed one single assessment, and so we needed to connect up our information systems. So one of the things that's happened for us is we have a Health One system, and it means that if you turn up at ED, for example, the doctor in ED, and you might be really unwell, you might not even be able to tell your story, but I think we all know that whole thing. If you're in the health system, you tell your story 5 different times to 5 different people. What we've got now is an ED, they look at what did the GP say about this person, what were their medications that they've been dispensed or that have been prescribed, what are they allergic to, what conditions do they have. And so our ED docs can see that. They can also see when were you last in hospital. They can see what happened in your pharmacist. We know that you were prescribed a medication. Did it get dispensed? And then they can see, are you receiving district nursing? What are the district nurses doing with you? And everyone in our system can look at what everyone else is doing. So we stop asking the same set of questions all over again. And so the patients, it's really about basing it on the patients and what they need. And so one of the things that we had to move to was getting better data and using it for continuous improvement. And a lot of what we'd done before was had reasonably poor data. We'd done a lot of comparative stuff and said, oh look, our rate of that's lower than other DHBs in the North Island, we must be really good. Our rate's worse than that. Oh, it's because we do something, and explaining away variation. We had to understand our own data better and see that in terms of a longitudinal view of what was happening to us, rather than cross-sectional. And so one of the things that we've done in one click on our intranet, everyone in the system can see a whole series of metrics about what's happening today or last week or last month to people, so that you can engage in what's the decision I need to make today. And so these are a series of data that's available, so that if I'm working in an acute medicine environment, I can have a look and say, how many ambulances have come into ED today? Because I know that 75% of those people are going to end up with me in about 4 hours' time. So you can start to plan ahead and make operational decisions. We also started to get people talking together across the system. And so we have four of the major hospitals now linked up with a common meeting, talking about where the flow issues are, where the staffing needs are, so that we can actually move staffing around even from hospital to hospital, not just within a hospital. And so daily meetings with data driving it. And you can see people in the room there making an operational decision at 11 o'clock about what's next, what we have to do now, tomorrow, to make things work later in the week. We also use really high-tech stuff around planning. And this is just bringing people into the room and recognising, actually, there's a series of actions, we need to be able to capture them. And this grew out quite organically out of this meeting, saying we've actually got to capture this because we're going to have to revisit it and know where we're up to. So some really simple processes, and they've driven a series of priorities. And our priorities changed. In previous times, we've focused very much on a vertical view of what a department would do and how we would improve that department. All of these priorities, or almost all of them, run across a patient journey, because a patient might go into a department, but their journey might be from ED to, or from their general practice to ED to an acute hospital bed to rehabilitation. And so we had to start viewing it as joined up and patient-centred rather than work-centred. This is one of those examples, the ability also to look into data in a longer term to be able to replan the system. We had to think more about what those pathways were, and this is a nice example where the senior doctors on the right-hand side of the picture said to their registrars, who might be 2, 3, 5, 10 years post-graduation, we need you to pull out the data and tell us what's working here. And so a way of digging in to know how we could redesign our system. And the thinking behind it was very much the Toyota example about rather than try and audit the defects, or for us, the harms after they happen, which is what we were doing, how do we build pathways and services that have capture those at the time and build quality into the product? So can we design a system where we don't cause harm on the way through? And that's very much the process now. So you can see they're building, this is just a typical patient journey, but also building a whole series of metrics around it to allow us to say, yes, we know we're doing okay here or not. Part of our job is to work with partners. St John are now a formal alliance partner in Canterbury, and as part of that alliance we work together. The interesting thing is St John Ambulance don't have their main contract with us. We both come to the table with what we've got, and it's around the patient. And so by working together we've been able to make some pretty stunning changes. So you can see there in terms of what most ambulance work is, it's actually older people, not injury, that drives the greatest volume of ambulance work. And so we'd worked with them, and you can see that part of that was a break at the earthquake. And if we kept on growing, their numbers would have still gone up. Their numbers are still going up, but that gap between those two lines of what's happened, that bottom line with the blue and green, with what we predicted would happen if we carried on doing what we were doing, is the result of St John stopping transporting people that didn't need to be going to ED and either treating them at home or transporting them to general practice. So we're not bringing a whole series of people that didn't actually need to be into a hospital in. So they've partnered, non-contracted, worked with us to create a better journey. And so in terms of what we've achieved, we've got the lowest ED presentation rate in the country and probably the lowest in Australasia. But we also have 30% lower acute medical admission rate than the national average, which means that you're 30% less likely to end up in a hospital bed if you're medically unwell in Canterbury compared with elsewhere. What does that actually mean for us? We're rebuilding a new hospital. We've got a $470 million hospital going in beside Christchurch Hospital, which we need as part of a rebuild for some of it was damaged, but some of it's our population. If we built it 30% larger at the national average, we would need about another 180 beds or $180 million. So we've been able to limit that. And then that bottom one is quite incredible because we can't see this anywhere else in the world. As populations age and go to hospital more, everyone's acute admission rates are going up. We've actually dropped the number of bed days. In other words, despite having more older people, they're coming less frequently to hospital. And so how do we do that? We have a program. This is one of the unique programs. It's been around a long time. We've ramped it up. And so there's about 30,000 people now who would have previously gone to hospital or ED who are now treated in the community. And most of that's by general practice, also with some community nursing. So the focus is how do we keep people in their own homes if it's safe to do so. I should say too, one of the things we learnt about funding was when we started out these journeys, we used to say, here's how much we'll fund you to keep them at home. And it doesn't really work because people end up gaming a system. You work out what works best for you. What we said was, you would have otherwise earned money for treating patients if you didn't have to look after this patient. So you might do a home visit, which would have stopped you from seeing 4 other patients. You tell us how much you've foregone to look after this patient, and we'll replace that. And so it is a very high trust environment of saying, we don't want you to be out of pocket, but it's also not a cash cow. And very occasionally people overstep the mark and we have a conversation with them afterwards. Because if the GP said, I'll do it, we need to back them. and then we can have a conversation afterwards about saying you've stretched it too far. Falls prevention. So this is in one way it's a physical activity program. It's for people that are over 75 at risk of falling, and we have the whole of the system referring people to it now. But we've still got work to do on this. And it's probably the simplest exercise or activity program that exists, because the majority of it is, we have 6 falls champions. They go into people's homes, they have a look to make sure there's nothing that you're going to fall over in terms of a rug or something similar. They also say and can prescribe any equipment you need, so if you need a handrail or similar. But the other thing that they do is simple seat to stand. So anyone over 75 that can't stand up without using their hands from a sitting position is at risk. And training your quads is probably the easiest muscle in your body to train, simply by sitting down or standing up and sitting down and repeating that. But having somebody come into your home to do that is how it's been achieved. And so we see about 1,500, 1,700 a year on that. And it has made significant difference. So those graphs are, the top left's ED. Probably one of the important one for us is the top right. The fractured NOF, or fractured neck of femur. So your fractured hip, when you have a serious fall, when you're frail, the risks of that are quite high, and we've had about 400, probably 450 fewer people with fractured hips than we would have had if we carried on the way we were going. And it also means fewer deaths, because the people that do have a fractured hip, we've got more time and focus on them, and so they're getting a better quality of care as well. One of the things that we needed to do was to be able to conceptualise a complex system in terms of our measurement. And so this is Canterbury's outcomes framework. And we said, if we've got a complex system that everybody's contributing to, we need to conceptualise this in a much more intelligent way than what we did in the past, which was to say, here's a driver diagram that says, if I do something over here, it'll affect X, that'll end up in an outcome. And we know that doesn't work. We know there's multiple inputs along the way. And what we said was, we're a system that's trying to work together around a patient. Let's stop talking about attribution and talk about contribution. So this is a model where the 19,000 people contribute towards the outcomes of the system. And so at the centre you can see Canterbury people are well and healthy in their own homes and communities. Really simple goal, a series of strategies that sit around that, and then in that outer circle that you can see there are 9 key outcomes that we believe are the most important things that we can do as a system. And what we said was, for each of these, we need to be able to break them down so that an individual can see, if I'm doing something like access to care is improved, if I'm looking after and making sure people are getting better access to care, that I can see where that's occurring, that contributes to one of these high-level outcomes that the system's trying to get. And not dissimilar to our analogy is NASA's janitor helping to put man on the moon. So everybody should be able to see what they do in here. And then within that, we look at a series of measures to say, so how are we doing on actually achieving those outcomes? And you can see there, this is our COPD or emphysema pathway back in 2012. We've got the most readmissions from it. It uses up the most bed days, and lots of people don't need to be in a hospital. And you can see the bottom blue bars, there's a 38% decrease in the number of bed days we're using for people with COPD. In other words, they're out in their own homes being looked after rather than having to come into a hospital bed. And this was where we started a lot of the work with St John. And you can see there's about the graph on the right shows there's about 30% of people who call an ambulance for COPD that don't get transported to ED. They either get treated in home and a nurse comes round within 2 hours, or they go to their general practice. And we've also trained them, so over time the number of people calling for COPD, because they realise they can manage it, has actually dropped. So people aren't calling an ambulance, they're starting to call their general practice so that they can stay in their own community. Here's increased planned care and decreased acute care, obviously really important how we manage the system so that we don't end up with the electives problem that we had. And so our goal was, and it was we've taken it from a series of points, so we've had an 8% growth in acute discharges or acute admissions over that 7 or 8 year period, compared with 29% nationally. So we've been able to keep that down over time. You can see I talked about acute medical bed days, that we've actually decreased those now over a period of time, which is the red line. And then on the right-hand side, the black line's the New Zealand average for acute medical admission rate, and ours is the blue line, which is about 30% below. At the same time, our hospital has got more efficient, and so the length of stay, in other words, the amount of time people are in a hospital bed, has decreased. And selling this was actually quite an easy sell. The evidence says the longer you sit in a hospital bed, the more you decondition. So getting up and rehab is really important. So the less time people spend in hospital, actually the better for them. I talked before about aged residential care. The top left graph is people over 75 who are living in their own homes. And so you can see there, over time, we're closing a gap with the red bars and increasing people who are able to stay in their own home. And that's because they're getting the right care and the right services. You can also see bottom right, there's where one of our issues lies in terms of mental health. The rate of access has gone up quite dramatically over the last 3 years, and we've got issues with that. So plenty of problems for us still to solve. And one of the things that we have to be really careful about is we don't believe our own press too much. And so mortality is an important thing to look at. And so is our mortality going up? Because we know that people coming into hospital are more complex. And so are we ending up with an adverse type event here? And you can see there, that's over an 8 year period, that we've been pretty static across time. And then the surgeon said, but are we just sending them out earlier for them to die out in the community? So the bottom two graphs are at 90 days and 180 days after discharge from hospital. And so important for us to watch. And no, we don't think we've done damage. But we do need to keep on watching that. And so to come back to our diagram and Agnes in the middle, one of the things that we've focused very much on is that complex system, and figuring that it's not just a hospital system, it's the whole of the health system. And if we engage in that, there's some elements in there. So some of those key elements are around a team-based approach, because it is all of us. And how do we devolve the decision-making away from centre to people who are actually delivering services, to make sure that they're enabled and can make decisions for the people that are in front of them, because they're the expert, not people like myself who've got a planning lens that are sitting way back. We're focused on person-centred solutions, and so to get a person-centred solution, you need to know what the person is doing and what they're trying to achieve. So once again, it's about devolving that. An enabling framework. So one of the things with an enabling framework was I spoke of funding. We've largely got rid of fee-for-service mechanisms because they drive the wrong series of behaviours. They're about how do I maximise the number of fees I can have. rather than saying you've got a resource and your job is to do the best job you can for Agnes. So we've moved away from a fee-for-service to bulk funding type mechanisms. And if people can create a better pathway or create efficiencies, our NGOs, great for them. Because it's creating capacity in the system, and we also have a trust relationship that if they do have extra resources, they're generally investing back into the community and we get the benefit of that. And obviously that last one on trust. So it's probably important to just mention our alliance for around that. The idea of the alliance was, and that move towards alliance contracting, very much the same as construction does it, in terms of bridge builders. They have companies that put in the piles. They have companies that provide the concrete, companies that provide the asphalt and that link up the roads. And they work together to move the resources around to achieve the best result. So everybody shares in that win. We've done the same thing in a health context for our alliance and say, we will, as an alliance, give you a resource, allow you to design the right services for the group of people that you've got. And so our alliances have specialists, general practitioners, nursing, they might have aged residential care, and they have planners all in the same room trying to work out what's the best solution here, and the ability to recommend actually will change what we're doing. And so I think our largest contract has two NGOs, one's a local one, one's a national one, and one for-profit organisation that are sharing a $38 million contract around how they provide community nursing. And they're able to come to the table and work out the best way to deliver. If they make efficiencies, that's great news for everybody. So very much on trust. So some thoughts about how we pull together that shared vision. It was more about a way of working, and that was getting everyone to buy in, and buying in around Agnes. Very easy to be patient focused for us, and you can translate that. It's the people that use the services that we're focused on. We took a whole of system approach. We stopped dividing it up and saying there's a whole series of parts. We're all in this around the patient, and we've all got a role to play. And it has changed the way we work. The idea of best care for patients goes as far as we may need to reorganise our structures, and from time to time we do that. So if it's going to be better for a patient, we'll let that drive any structural reorganisation. And I think one of the things, because I started in 2008, there's been no structural changes in the executive team since I started, which is quite incredible. There's been some times when there's been a shift in emphasis or taking advantage of natural changes, but there's been no structural stuff. Everybody's focused on the operational side of it. How do we improve it? And it's ongoing. There's still, as I've said before, there's still plenty of challenges for us. And look, they're very much the same limitations. There's a limited amount of resource. They've got a whole lot of different people with different interests and priorities. Organisations have their own viability to worry about and to think about. The information, like I think Mai's conversation around information is really important. In health, we have oodles of information, but we use it poorly overall, and we don't link it up across the system. The most powerful information we have is when we put two pieces together, a community intervention and to know what's happening there, and then a hospital example, so that we can say, that had an effect. But we've still got challenges there, and we're working really hard on that. And then the last one, it's easy to get caught in your own little battles, and so it does come back to being focused on the person in the centre, and most of all the people. Thank you.
We've got time for one or two questions, if you're okay for one or two questions. Are there any questions for Greg? Yes.
I'm intrigued to understand how you got the normally reluctant various bits of the medical profession to step outside their silos.
Yeah, look, it's philosophical and it's engagement. And so each time we do something like, I talked about one system, one budget, and that engagement was with their peers. And the first time they went into the room together, the most common sentence was, when we put the specialist with the general practitioners, "Oh, g'day John, I haven't seen you for 15 years since med school, but I flick a few patients through to you." And so those conversations were really important because everybody had a shared interest in the patient. And so they had to get out of their silo. And so the GPs say, "Oh, it really annoys me when you send them back because I've sent them to you for help." And then the specialist said, "Oh, it really annoys me when you say, 'Oh, please see, can't pee,' to a urologist, because there's not enough information." And they started to have that conversation. "Well, what do you want us to do?" And so the specialists were able to say, "Well, if you work up this and do this test, and you've already done this therapy with them and it's not working, I'll definitely see them." And so that journey, and it's a conversation, was about saying, what do we each want? And then, of course, general practice was able to say, "Oh, fantastic." And our job became, "Oh, look, we'll pay for that diagnostic on the way so that you can do more, and you don't need to send it to a specialist to get a diagnostic. General practice can do it." So and it's self-fulfilling. Once people start it, they trust it. In the first 2 years, we built 5 pathways I talked about those pathways of where patients flow through, and now we have 761. And after the first 18 months, people saw, "Oh, gee, they're getting stuff sorted for them. I want it." And we almost created a new waiting list in the system.
One more question? Next.
If the DHB's looked at this model and taken it on board?
Yes and no. DHBs are very tribal, and we don't share as well as what we should in terms of successes, but it's not entirely, that's at a first look at a high level. On the other hand, we have the system I talked about, the 761 pathways. 16 out of 21 DHBs now have our system, but evolved and adapted for their own system. And we've also got it in 16 systems in Australia. And so, yes, there are elements, and people share elements and want to learn. Yeah, and I think DHBs are getting better, but still tribal.
Great. Some of you will recognise the diagrams that Greg used. I'd like to suggest that DHB flogged them off us, but in fact we flogged them off you guys. And actually we're very much following your patient-centred approach with a participant-athlete-centred approach. So it's been pretty useful, actually, our engagement with you. If you can all join me in thanking Greg.